Welcome to the Unspeakable Podcast. I'm your host, Meghan Daum. So this episode is about therapy. Psychotherapy, or any kind of counseling for mental health issues, is supposed to offer a safe, non-judgmental space for patients to talk about anything at all, especially their darkest or most confusing thoughts or emotions. But I have heard a lot of people talking lately about being afraid to bring certain things into the therapy room, especially issues around politics and identity, for fear of being judged or even admonished by their therapist, even called racist or sexist by their therapist. I have also heard people say that they had a therapist who was poised to frame all of their issues as stemming from things like racism or sexism. In other words, it's not your mother's fault. It's systemic discrimination. I have also heard therapists. I talk to people a lot about therapy, I guess. I've heard therapists who don't practice that way talk about their fears of being censured by peers or colleagues in the profession for not being progressive enough. Now, this sounds kind of unbelievable, and 10 or 15 years ago, it might have been. But our current landscape has made these dynamics all too real, which is why my guest, clinical psychologist Dr. Andrew Hartz, founded the Open Therapy Institute. In this conversation, he'll tell us what that is and also explain how and when things started to change. We talk about what kinds of people become therapists, how unchecked empathy, that's my phrase, not his, can lead to bad therapy, and how he feels about sessions conducted on Zoom, as well as new models like BetterHelp. Just so you know, there is no bonus portion of this episode. So if you are a paying subscriber on the Substack, you get a break this week, or I get a break. If you are a founding member, I am hereby announcing that I'll be hosting a Zoom hangout on Sunday, October 29th at 8 p.m. Eastern Time. I do these every few months, and they're a lot of fun. So please do become a member at that level if you are not already. You go to meghandom.substack.com. And with that, here is my conversation with Dr. Andrew Hartz. Andrew Hartz, welcome to The Unspeakable.
Thanks for having me.
You are a practicing clinical psychologist. You're also the founder of something called the Open Therapy Institute, which I want to talk about, as well as your practice. But I'm actually going to start with telling you about something that is central to the reason that I asked you here. As my listeners know, probably, since I've been writing about culture war issues, and even more so since starting this podcast, I hear from a lot of people who are caught in the ideological crosshairs. This led me to start a women's community, actually, devoted to viewpoint diversity. We have retreats all over the country. We have an online community. It's a private community. We never reveal the identities of anyone who comes on a retreat or who joins us online. Most people wouldn't care if we did. But I can tell you that the profession that by far represents the highest number of people who do not want it to be known that they have anything to do with our group is therapists. They are terrified of having it get out to their patients or their colleagues that their views are anything but boilerplate progressive. And they come from all over the country. These are not just people in Los Angeles or San Francisco or New York. They're all over. So my first question to you is very simple. Why?
Yeah, it's a really great question. Okay, actually, I have some thoughts about this. One of them is so much of therapy for so long was about being open to whatever people are feeling. Like if you go back to Freud and his essays on free association, the patient's supposed to free associate and kind of say whatever pops in their mind without censorship. And Freud says, the stuff that you feel like you shouldn't say because you don't want to say it or it feels irrelevant or, whatever, that's the stuff that you want to be most sure to say in therapy. So the whole method is all about saying the things that you would normally self-censor. That's how talk therapy started, over 100 years ago. So it's weird now to have the mental health profession become such a censorship culture and become so ideologically one-sided. And people I think, feel unable to talk about what they're feeling. And therapists who historically have been most attracted to like unfiltered free flow of thoughts and feelings, are probably more sensitive to how impactful it can be to not be able to do that. Even in therapy, and even in professional contexts, people feel like they can't really say what they think and feel.
And when did you start noticing this happening? How long have you been in practice?
So I started my PhD in 2013. And at that time, I didn't notice personally any politicization in the field. Politics didn't come up in training very often at that time. They didn't come into the therapy room very often either. I think a patient who wanted to talk about the news every day, that would have been seen as weird.
That would be something to work on. I might
Yeah,
imagine.
it's like, why are you here to tell me about the news, But I'd say 2014, 2015 is when I started to see changes happening. And then in 2016, politics became a real focus of the field. And then that just kept escalating every year through the end of my degree, to the point where by my last year of training, I would have one a week, even more trainings on political issues, especially identity politics stuff. And those trainings had a really different character than the other types of trainings, where in a lot of discussions that therapists have, they're like open about a wide range of thoughts and feelings. Therapists tend to pride themselves on their ability to have dialogue about different difficult issues. But the ones that were identity politics focused, you got the sense very quick that dialogue was not welcome. There was an idea that you had to adhere to unquestioningly, and any challenging or questioning or deviation from that was going to pose severe social and professional risks. And you could see in those conversations, by the end, the way that people are clearly stifled, clearly inhibited, looking at their shoes, agreeing passionately with everything. Nobody ever says anything contrary, that it was just a very weird, I think, unhealthy group dynamic that was present. They just had a very different character. And that character was just seeping into more and more of every conversation and every meeting in the field. So it just became very, very politicized in a relatively short period of time.
Now, you're talking about these meetings. Are these meetings like this is training within your psychoanalytic institute? Because I think it might be helpful to explain how therapists get trained, because I think sometimes
Right.
people have the perception, and it might not be wrong all the time, that like you can sort of just hang out a shingle and be a therapist, or be a licensed clinical social worker, something like that. Not that that's hanging out a shingle, but maybe you can explain what kind of training you were getting and what is the education course for a therapist generally.
Well, I'm a psychologist, and psychologists get a doctorate.
Right.
I have a PhD. That program usually takes somewhere between 5 and 8 years, depending on what your program is like. And then there's also master's level clinicians who might get a 2 or 3 year degree, sometimes even a 1 year degree. And it varies by state. And then you have to pass an exam and get a certain number of hours. You're right to say that there's a huge variety in the different types of training people get. They get trained in different types of therapy, different types of populations. The quality of the instruction and supervision they get varies really wildly. So there, it is like an apples to oranges thing, where you can have two psychologists who both have a PhD in clinical psychology, and they just learned totally different ways to do therapy with totally different types of people. For me, I don't want to name specific institutes here, but like I did train at a psychoanalytic institute in New York for a couple of years, and I trained at 3 different hospitals in New York, and they're really, really major hospital systems in New York. And on those different training placements, usually like I had one going each year about. Sometimes I was at multiple sites. But for the most part, that's how it works. And I'd have a variety of different trainings, like how to do a neuropsychological assessment, therapy with kids, therapy with adults, couples, family. You have some lectures, you see patients, you'll do inpatient psychiatric care. There's just a wide variety of things, groups. And so that's what it looks like. And you're there at maybe a hospital for a year, and then you go to a different one, or you're at a university clinic or an analytic institute or something like that for a year or two, and then you go somewhere else. And that's what most of my peers' training looks like as well.
Okay, so you were seeing patients in an inpatient setting, sounds like.
The hospital, most hospitals do outpatient psychotherapy and inpatient. So at every hospital, I did some outpatient psychotherapy, probably mostly outpatient psychotherapy, but I did a lot of inpatient rotations too.
Okay.
Yeah.
And what was the patient population like?
It varied. I mean, in New York, at the public hospitals, it's a lot of Medicaid, Medicare, low income, immigrants, but people with severe mental illness, people with personality disorders. And then it kind of ranges to, at some clinics and hospitals, even higher functioning, more well-off people. But I think most of my training was probably in much more difficult cases with people with multiple diagnoses and more severe diagnoses.
Okay. So how was identity politics coming up in the context of this kind of population? Like, you would come into supervision, and also maybe you want to explain what supervision is, and present your cases, and how would your supervisors respond?
Yeah. So supervision is like, there's usually two types of supervision that most trainees will get. One is individual supervision. You'll meet with a licensed therapist for like 45 minutes once a week, and you'll review your cases one by one, talk about important clinical issues, and get their advice and feedback about how to handle them. They'll review your notes and your paperwork and make sure it's up to par. And then there's a group supervision where, a group of trainees, somewhere 4 to 8 trainees will be in a room together, maybe for a couple hours even, with a licensed therapist who will talk them through broader, more general clinical issues. And maybe people will rotate presenting cases or talking about difficult issues. So that's what supervision refers to. I think there was one clinic that I was working in where they seemed to make the formulation of the patient entirely based on their demographics. So if I went in, and this is towards the end of my training, but if somebody said, well, I have a patient, she's upper middle class and white, and she has anxiety, they would say, well, she's anxious because she's privileged and her issue is white privilege. And then they'd be, well, this is somebody who's lower income and she's Black, or she's an immigrant. And then they'd say, well, this is obviously a result of systemic racism, and she needs to connect to her anger about racism and use it to motivate her activism. I mean,
wait, this was really happening. Sorry, hang on. This was really, and what year?
I don't want to say, I don't want to say
just so
where
we
it
get
was.
like not where it was, but what year. Like, I just want to get a sense of the political and cultural climate.
It was during the Trump presidency.
Okay. So, okay. And these were people in a supervising role, and the other trainees were just nodding along with this and saying like, that makes perfect sense. Thank you for illuminating me.
There was this is my assessment of the group dynamic. There was clearly a ringleader who was a Black woman who was incredibly aggressive, and she really intimidated everybody. And even the head of the clinic, who was not her, was scared of her because she would just go for the jugular vein every time. But she had a number of like devoted followers who had drunk the Kool-Aid. Maybe there was, a couple dozen people in this particular facility. And, and there were a couple people who would really rally behind this and agree. And then there was a lot of lukewarm people. and then some people who were looking at their shoes, and they were scared. You don't want to like not, you spend so much money and so much time getting your PhD. You don't want to blow it up
Right.
in your last couple years. You just got to get through it. And I think there were plenty of people there who recognized that this is like a damaging way to think about people. But it's not like, this way of thinking, it's not like unheard of. If you look at like increasing papers in the field and what's presented at conferences, you can see this way of thinking manifesting.
Oh, yeah.
And so it's like, it's actually like in print. It's
yes.
not like, yeah.
I've had Helen Pluckrose on this show. Yeah, no, my listeners are very familiar. But okay, so the woman who was having this approach, and I don't mean to, we're not going to dwell on this particular setting, but do you feel like 10 years earlier she would have had that approach? Like, how recent did it feel?
Well, I can't say that for sure. It just seems like it would have felt, I just didn't see it at the beginning of my training. And I had this sense that environments were trying to be open. They were liberal. And if you were like, racism is playing a role here or something, people were like, oh, sure, I should be like attuned to that. Or like, people, it wasn't like there was no politics or no identity politics at all. But I just the amount of aggression and intimidation and the like way in which it shapes every case. Like when you present a case, people probably don't know this who aren't in the field, but when you're at like a hospital or a clinic and you're going to present on one of your patients, the first thing you say, you have a first sentence for how you present a case. This is not new, but you'd say like, my patient is a 38-year-old white male. I mean, maybe in older days they would have just said male, but now it'll be, my patient is a 38-year-old cisgender heterosexual white male who is presenting to therapy to treat depression. That formulation of that sentence is the way you start your presentation. So, but it kind of, that sentence has gotten longer, and I think over the past 10 years, where it's more identity categories are included, like immigrant, woman of color, cisgender, heterosexual. Like it's become, and then and it's also become the place where the clinical thinking is entirely focused, and it seems like the other factors of the story about like their family history and their relationship history and their thoughts and feelings and stuff. It's almost like it takes. It's not every time, but I just saw a lot of case presentations where it seemed like they were just entirely focused on the first part of that sentence.
Okay. So really the upshot here is that psychologists and other clinicians are being trained to take this approach. And obviously that changes the dynamic in people's therapy. So what happened when you finished your training and, went out and were in clinical practice all the time? Were you seeing the results of this kind of dynamic come up with the people you were working with? I mean, were they coming in and saying like, oh my gosh, the last therapist I went to, I felt like I couldn't say anything, or we got into it. I mean, I have heard stories of people saying like, I felt like my therapist yelled at me. I mean, it's astonishing.
Yeah. That stuff is happening. I don't want to overstate it. I think especially if you're in solo private practice, I think the incentives against treating your patients in that type of aggressive way are pretty strong because this is your income source. If you have a tenured position somewhere or you're entrenched at a clinic or a hospital where it's going to be hard to get rid of you, you kind of have a captive population, there's more of a temptation to abuse your power. So I think it depends on where the person is. I have had patients come in saying like, oh, okay, like I have heterodox thinking about gender. Is that okay to talk about here? And, or something like that, or masculinity, and so it comes up there. I think my concern about clinical care right now is, yes, I think there are increasingly really atrocious things that are happening, like I just described. My bigger concern is that there are huge populations that are just being chronically overlooked and that they're not really being understood or supported. And there's very little literature about them. There are not therapists that are advertising a specialty in working with them or skill in working with them. And if they just grab a random therapist, there's a good chance that they will be misunderstood. And I think this is basically anybody with a heterodox opinion on anything where that feels relevant to their therapy, which is a lot of people. So if I'm at work and I have to go to lots of trainings that I feel like are hateful, or I feel like I can't say what I feel, or I feel isolated because of it, and this is a difficult issue for me, and I want to find a therapist would be helpful. There's almost no one who lists themselves as working well on that issue. And there's not a ton of literature about it. There aren't a lot of case studies about it. There aren't a lot of treatment recommendations about it. And if you just find a random therapist online, what are the chances that, there's a small chance that they would be openly hostile to you or not even want to see you or avoid the issue or pathologize it. But even if they don't do that stuff, are they really going to be are they going to be helpful? Are they going to have anything thoughtful to say? Are they going to understand the experience and actively be supportive? So I think that's more my concern, is that the clinical competency with a range of populations is just not there, because as the field is getting systematically politicized, there are all these groups that are being overlooked, and therapists are uncomfortable working with them, unsure how to work with them. They avoid the issues. And it's like, I don't want to, I think there are a lot of therapists who might think, well, I've never kicked a patient out of therapy because of their politics, so therefore I'm doing an A+ job, and it's like, it's bigger than that. And my guess is actually that a lot of people who are isolated or antagonized at work, or dealing with these censorship issues, or have been fired or disciplined, or they're, things like that because of their views, a lot of those people aren't even necessarily thinking about therapy as a place to figure out what to do.
No, they're running to Reddit. I mean,
Yeah.
then you end up with this whole kind of population that's very angry, and I mean, rightfully so often. But there's all kinds of corners of the internet that will, that you can sort of run to for shelter, but then it ends up just perpetuating your bitterness.
But to actually have a place to put together what's happening in your own context and get your head screwed on straight about it, think about what your options are for how you respond in a way that feels right for you, get a vocabulary to kind of start to understand some of the interpersonal dynamics and your experience of them. I mean, there's a lot of things that could be really helpful for them about getting support, but there's nowhere to go for support. And I think that's my biggest concern, is that there's just a ton of people who are really stuck, really stifled, really struggling, and there's no supports for them.
Right. So that's, I'm assuming, why you started the Open Therapy Institute. What's the concept there?
That's the concept. The concept is that there are a lot of different types of overlooked populations that have some of these populations have virtually no clinical literature on them, no trainings on them available anywhere for therapists, no services, no clinics, no specializations. This could be obviously people who are canceled in one way or another, people who are isolated and self-censoring, but also people who are struggling with masculinity and want an authentic sense of masculinity that feels right to them, but they don't want to get divorced, or they don't want to or they're struggling, or they've dealt with anti-white hatred in its variety of forms. There's men who have been falsely accused of sexual assault. And there's one psychologist who talked about an issue of abortion regret, and women who have gotten abortions and regret doing that. And it's just so a lot of these issues they have, there's firearms issues, the way that firearms are often pathologized in an unconstructive way in mental health. There's just lots of issues where There's virtually no literature. There's very few to no trainings. There's no resources for people.
So you're talking about normal people. It sounds like what you're describing is like basically most people outside of major urban areas.
You
like
need a lot of people inside of major urban areas too.
That too.
Yes.
Yeah.
Yeah.
Yeah. And yeah.
Anybody with one heterodox belief is going to struggle to find a therapist who's going to get it. And a lot of these people, if they do go to therapy for one reason or another, I think the mistrust of the field is very high. But if they do manage to go to a therapist for something, the chance that they're going to self-censor really important values and experiences is very high. And the chance that the therapist is going to be totally oblivious to this and not really foster openness in an active way is also very high.
So how is the Open Therapy Institute structured? Do you have therapists that get training through you? Do you have like a roster of therapists? Like, how is it? What are you offering?
Yeah, we're focused on two things, which are therapy and workshops. The main focus initially is that people who contact us, we will connect to a therapist in our network who we've interviewed, and we're trying to develop like a skilled professional community of talented people who get it and want to work on these issues. So that's one side, is the psychotherapy side. The other side are trainings. You know, we do want to offer workshops for the general public at some point where people can like learn general skills about these issues, but we're going to focus first on continuing ed for therapists, just teaching therapists about some of these issues, starting to ask questions, starting to make recommendations about how therapists can treat some of these overlooked populations and some of these overlooked issues in the field.
And are you seeing like particular demographics with respect to the therapists themselves? Do they tend to be over a certain age? Do they tend to be in certain areas of the country?
You know, that's a good question. I think we have a pretty good spread of people in terms of age and even race and religion and geographical location right now. It would maybe that's surprising, but like I would have guessed like what you're saying. Like I think I would have guessed that it would have been people that are older, and it's less likely to be millennials. You know, I don't think that's been entirely true. I maybe would have guessed that it would have been more men. I think it's probably much more women.
Well, there are more women therapists, aren't there?
There are more women therapists. So maybe if you control for that or something, it does have a slight male. I don't know, but I think it's right now it's a pretty diverse group, and it's a diverse group even politically. Like we obviously there are some conservatives and Republicans involved, but there are plenty of liberals and Democrats involved, and libertarians and moderates, and so it's a pretty interesting spread.
We're going to pause here for a brief message. Hi, it's Meghan. I hope you're enjoying this conversation, and I promise I'll get right back to it. But you may have noticed that there's something missing in this podcast: ads. I don't run them. I don't do host reads, and I decided a long time ago that I will not run programmatic ads. They're simply too disruptive, not our style around here. But that means that the only support I get for this podcast comes from paying subscribers. This thing is entirely my own. It's not affiliated with any organization or secret cabal of funders. I do it because I love it, and I'm committed to bringing you candid, respectful, surprising conversations that you won't hear anywhere else. That's why I'm asking you to consider becoming a paying subscriber to this podcast's Substack page, which you can find at meghandom.substack.com. For as little as $7 a month, you can get bonus content nearly every week, access to my new writing, the chance to participate in comments, and a lot more. If you join at the founding members level, you can meet me almost every month for a listener Zoom hangout, where we talk about the show and discuss how to pronounce my last name. To do that, go to Meghandom or meghandaum.substack.com. That's MEGHANDAUM, and join us. It helps me out tremendously. So thank you. And now back to the interview.
the issue is competency. And I think that the concern, I don't know that I would want to see a conservative therapist or or I want to find a therapist who shares all of my views on things. That's not what I'm looking for. But I am looking for somebody who's open and could have something helpful to say about the issues that I'm actually dealing with.
Yeah.
That matters to me. And somebody who's, and not open in a sense of like, okay, well, they're not attacking me, but they're just staring at me blankly. That's not really openness in my opinion, but somebody who actually can see how much the issues that I'm really struggling with matter to me and can help me talk about them. And a lot of those for me, personally, like do have to do with masculinity, gender, race, religion. Those are important issues for me. And it's unimaginable to me that I could have an effective therapy where I avoid talking about all of those issues. And also just like, I don't want somebody who's just going to like put up with me talking about those issues and then, and that's it. It's somebody who actually can see that and not somebody who's going to either simplistically pathologize them either, but like actually can respond to them in a therapeutic way. And my guess that's what most people want. Most liberals want that. I would guess most centrists and moderates want that, and most conservatives want that too. It's not realistic to have your therapist agree with you on every issue. Like your therapist can't agree with all their patients on every issue.
You have to pay more
and it's not
for
the
that.
point. It doesn't matter. It doesn't even matter. It's just like you have to be able to like think empathically and clinically in an engaged way that's respectful towards the range of experiences. And a lot of people are it's so sad how many people are having really, really awful experiences and feel like there's nowhere they can go to get support. And there really isn't.
Yeah. Well, again, they go online. I mean, they find these sort of spaces. Well, can you give examples of issues that people have come in with either to you or other therapists in the Open Therapy Institute?
Yeah. I mean, I think basically, the list is like almost infinite. I mean, it's somebody who can't get a job because they don't want to get the vaccine. It could be somebody who experienced anti-white bullying through a lot of their childhood. And then, that's an interesting experience too, because I think that's one that's like systematically overlooked. And, it's crazy to think about, especially like white students who go to majority non-white schools where a lot of the anti-white bullying it can be pretty entrenched and obvious and pretty overlooked. And then, you get bullied on the playground or whatever, and then you go to class and you're taught how you're privileged and you have to apologize to your bullies for your race or whatever. I mean, it's kind of like and you just think like, what are these people like? You either, in that context, you either like fully internalize it and despise yourself and want to be something else, or you rebel against it and like become a white supremacist or something. It's very hard to like, especially for a kid, to like respond to that situation in a really mature way, especially when there's no outlet for you to talk through and process your feelings about those experiences. I just think it's so bottomless, the number of issues that people have, but especially maybe people when something's happening with their kids is a big one, or there's like family and couples issues, stuff at work. Like, especially as workplaces become really politicized and there's really clear signals sent that this is the ideology that you have to be behind, and disagree with it or question it at your peril. That can really wear on people to be in that environment every day. And you go from having been somebody who loved your work and loved your colleagues and couldn't wait to show up, to just being burnt out and hating and wanting to retire at, 35 or 45. And it's just like, it's crazy how poisonous that can make a space and make someone's life.
I want to ask you, what kinds of people tend to go into psychology, clinical practice clinical social work, that kind of thing. Because this comes up a lot on this podcast. I talk a lot about gender, the new gender movements. I've had people on here talking about issues with children and gender, youth medicine, transition, that kind of thing. And it seems like the people who go into therapy, especially around gender issues, just tend to be a certain kind of, not even like necessarily political leaning, although that too, but a certain personality type or temperament. Like they're just very resistant to confrontation, strangely, or they're just, I mean, Sasha Ayad put it this way, and I think this was, Sasha Ayad and Stella O'Malley do the Gender A Wider Lens podcast, which is phenomenal. I think it's the best gender podcast out there. And Sasha has said, they tend to be these kind of real, like hyper empathetic people, sort of bleeding hearts. And there might be even, and I don't want to put words in her mouth, she didn't say it this way, but it seems like there's just a kind of baseline resistance to critical thinking, or almost fear of critical thinking in the population of people who go into this field. And I wonder if you have thoughts about that.
Yeah. It's so interesting. Like, I definitely had peers going through my training who I think were almost all women, and they thought the job of the therapist is just to like sit there and be nice.
Mm-hmm.
And they really thought that was the job. It's like, you're there, they come in, they have a space, you're nice to them, you like say nice things to them, and that's your job. And it's like, and maybe there's like more of a sophisticated rationale around that, about like attachment theory or empathy or what they think about that. But it seemed like that was a big part of how they practiced and how they conceptualized what they did. I think male therapists, and this goes back even like to when the field was more male, at the beginning when it was like mostly men, and where it's like, no, the therapist's job is like interpretation. And like, you make interpretations and you're formulating, it's like a totally different, it's like,
I'm not sure that's any better. I don't know
yeah,
how they're thinking about it.
You're formulating what's happening and making interpretations.
Right.
But it's like, but I think
it's kind of, you're like, mansplaining back to the client what they just said.
Exactly. But you kind of like, so I don't know that I think that there's like one type. I know too many therapists that are like too different to like say that there's like one type of person in the field. I think there's just like lots of there are different there probably are some commonalities if we like broke it down, but like, yeah, I think there's a range. The field has become more feminized. And,
well, yes. I mean, what percentage of therapists are women at this point? Because
it's probably like 80. It's probably like 80%.
Yeah. So that, and is that like in the last 20 years, 30 years more?
I don't know. I don't have the data offhand. And it's like, and it is like, this is like another thing, but it's like, if you look at child therapists, it's even more female. Of the male therapists, what percentage are gay? Probably half. It's like, the percentage that are like, I am definitely in the minority as like a heterosexual, male therapist. But I guess of the heterosexual male therapists, like what percentage are Jewish? It's like, they're mostly Jewish. So it's
right.
there is like this kind of like, okay, like cis, hetero, non-Jewish male therapists are like just this tiny, it's crazy how small of a percentage there.
Yeah. And so, like, again, this is something that comes up here. And then also on my other podcast that I do with Sarah Hayter. I mean, we talk often about the sort of the feminization of the culture and the way that like this kind of feelings-based, very sort of almost like pathological empathy is how I would put it. I just thought of that right now, but I'll have to think about that more. But like there is this kind of baseline, feelings are more important than reality. Like this sort of permeates so much of the public discourse, but also private interactions that we have with people who are supposed to be in the helping professions. And I wonder if there is a kind of like degree to which a female sensibility has hijacked this process. And I'm saying that. You're not saying that. I know it'd be hard for you to say, but you can just nod. I know this is audio only, but you can nod along.
It's hard to see. I always heard empathy in my training was it was about accurate empathy in the sense that you're thinking, I'll tell you what I'm doing, what a big part of what I'm doing in the therapy room when I'm working as a therapist. I'm listening to what the patient is saying at a verbal explicit level. I'm also listening to the affect of the emotion that's expressed. And I'm also listening to what I'm feeling in response to it. And those three different, this is a not my model. I didn't invent this, but it's those three different pathways are each giving you information about what's going on. And it's not unusual that someone says there's no issue, their tone seems calm, and I'm feeling totally flooded with anxiety.
Huh.
And it's well, so I'm wondering, are you feeling anxious? And they're like, yeah, I am. I was like, and then you see where that goes. Or they say, they're angry about something, but you listen to it, and it's it seems like the driver of the anger is feeling unheard or feeling powerless or something. And you can sometimes then talk about, that sounds really disempowering or something. It might be something that a therapist would say. And then they're saying yeah, it's really disempowering. And then when they can connect that feeling of being disempowered, it takes some pressure off the anger. And it actually the anger isn't quite as overwhelming because they can talk a little bit about this other feeling that's feeding it. I think of this stuff, in my view, this is the best, most positive reading of what empathy is. But in my view, this is what empathy is. It's I am listening to emotions, not just to say, feel whatever you feel and I'll be nice and validate it, even if it's crazy or distorted. That isn't really empathy to me. I think of it as accurate emotional reflectiveness. So I think there's I do hear what you're saying about there's a way that empathy can become this monstrous and dysfunctional thing. And I think that is you were pathological.
Well,
empathy.
Radical empathy is a real term that you hear thrown around. Put radical in front of anything.
Radical empathy. Yeah. That it's I'm gonna, and there's sometimes an exclusiveness to the empathy. I'm going to really empathize with this one person at the expense of empathizing with this other person or something like that. Or I'm really going to empathize with this side as opposed to this other side. I think it can totally get unhealthy and derailed. But if it's done right, I think it can be a really valuable clinical tool.
Well, I imagine this comes up with couples a lot. Do you do couples therapy?
Yeah, some. It's not my main bread and butter, but I'm usually seeing a couple or two.
Yeah. And in your experience or from what you've heard, do you think that men are discriminated against in couples therapy? Does there tend to be, it's probably more likely to be a female clinician. Is she
female
likely to side
clinician
with
and
the
the
woman?
female patient is the one who's dragging them there, and the man doesn't want to be there. Yeah. And I think there's definitely there's definitely a whole set of assumptions about gender that probably most clinicians aren't even aware that they have going into it, about what gender roles should look like, what people should feel about them, what needs are valid, what needs aren't valid. Somebody who's a man who's I want to, who wants a maybe more traditional male role and wants to be valued for that, that's I think much more likely to be seen as problematic. And there are these weird, one thing that I think is weird, especially I'm in New York, and I think I see it, I wonder about it in New York, is where you have two couples or two people in a couple, and both of them are kind of sexually and emotionally attracted to like gender. So they kind of want some role differentiation there.
Wait,
And
what do you mean they're emotional? They're attracted to gender? You mean like they're attracted
they're attracted
to
like to tradition, maybe like traditional gender. Like they're
the opposite,
features
like
of
they want
tradition.
they want the sort of, if
It's
you're a
not
woman, you want a
necessarily
more
like it has to be. It doesn't have to be Mad Men and like
right.
it doesn't have to be like that. But there is like a like yeah, when the man like works more and the woman cooks dinner, it's like there's something that's like emotionally gratifying and maybe even erotic about that. And that
I don't think that's just people in New York. Yes, maybe people in New York have a cognitive dissonance about it. Yeah,
that's what I was saying.
Right.
No, not that they're the only people who do it, but that both people in the couple can like seem like they want that, but be unable to admit to themselves that they want that. That's what I think I see in New York. I definitely think it's not the only place where people, but there is like, so they're almost like trapped in this dysfunctional dynamic that's not gratifying to either of them because they feel morally obligated towards this ideology that they don't even really want. And like, I think like women would feel like if they want that, then that means they're not like a boss bitch. They're not like, a feminist, and like they're not as successful or something. But then the men feel like if they want that, then they're like a patriarch and they're sexist. And
oh my gosh. And is this generational? No, I know exactly what you're saying. And I feel like, so like I talk about generational divides too much here, but like, I feel like around people like I'm in my early 50s. So I feel like there's a little bit of that in my cohort, but I feel like I see this more in younger people.
Yeah. I think so. They're more, and it's because a lot of like education and college and media really set cultural norms. And then you can find somebody where you're like, we're going to actively challenge these norms. But you really it requires more drive on both parts and more honesty and candor. And I think maybe maturity even on both people's parts to say we want a, equitable, mature, loving relationship, but we want one with gender. And that means that some of these kind of symbolic things are divided up in this particular way. But it's also just like, there's something crazy about this task that like couples have to, because the norms are where they are, or at least they're established culturally in a particular place for a lot of people, they have to kind of relitigate and renegotiate all of these features in every couple. And it's like this endless source of potential arguments and friction it's just part of being a couple. I don't know, like right. you either like say, okay, well, I'm not going to get everything I want. I just have to like deal with it. Or no, this is something I want to fight about. It's just like, it just sucks.
Yeah. Well, it's pick your battles. Yeah.
Pick your battles. But it's like, but then it's crazy that you can have two people wanting something different from the status quo and unable to like admit it to each other. And I think you get this even in therapy where there's therapists who are, they really get some of these cultural issues, but they're shy, to actually communicate that to patients. There's this, whereas like, I think it's probably therapists who are fully on board with social justice ideology are less shy about jumping in with their patients.
Yeah.
I totally agree with you on that.
Yeah. Yeah. So like in terms of the gender thing, I don't know how much this comes up in your own practice, but I'm imagining that it is relevant to the work of the Open Therapy Institute. We constantly have this conversation. Why are so many clinicians on board with gender ideology? So like often the women that are in my Unspeakeasy community, the ones that are therapists, I get the sense that one of the things they're most afraid of is being known around town as the therapist that is not going to be gender affirming. Why is it that this movement is so pronounced? Why is it like the people who went into this field just tend to be a certain kind of person? like I said before?
I mean, maybe that's playing a role, but I mean, okay, I actually have a little anecdote here. When I started, this was one of my, I guess it was my, I won't say what year it is, but one of my early years in training. I had just started, and I had a trans patient who had a kind of atypical kind of trans identity, and also sex addiction. It was like not a great case for an early clinician because it was extremely difficult. And I was like, I need a supervisor. Like I need somebody to talk to get help about how to do this. And nobody knew anyone.
At all.
Like, at all.
And this is in a major city, I'm assuming.
This is in New York in the couple of years before Trump became president. Mm-hmm. And it was like, nobody knew anyone. And I was like, well, what do we do with this? And they're like, we don't know. And so like I took abnormal psych and intro to psychopathology and all these kinds of classes that talk about the DSM. And I think in the ones I took, gender dysphoria was not even part of one lecture. Like it was so not an issue in 2013, 14. Like it was like, and then I remember seeing it on TV, seeing like on this show where there are a bunch of celebrities talking, saying that there's a well-researched clinical consensus on this issue that, people need to be able to be trans and use up the other bathroom or whatever. And I was thinking, I haven't been to a single lecture around that. And I remember when this started happening, when the like cultural zeitgeist hit, which was very abrupt for the general public. It was just as abrupt in the mental health field in terms of what I saw, where all of a sudden there was this huge demand. This is what it seemed like. Again, anecdotal. This is my perception, but it seemed like there was this huge demand for trainings around this issue. And I would see on the listservs of therapists like, we need trainings on this because people didn't have it. So like most people in the field knew virtually nothing about this until it was announced through the media that our field had a consensus on it. And, and I felt that it was communicated from on high. Everybody needs to agree with this. But the people that were actually doing research on this and that were knowledge about it were few and far between.
That's fascinating.
And the program was really different too. I mean, and I remember this was early in my training, and this is what I didn't actually see this patient. It was a colleague, but she saw a patient who was identified as trans, and it was like they had to be in therapy this was an adult, somebody, late 20s or early 30s, had to be in therapy for a year and get a letter from both the therapist, a psychologist, and a psychiatrist in an evaluation.
Oh yeah, no, that's how it used to be. But that's gatekeeping.
That was gatekeeping. But that was like, I want to say that was like 2017 or 2018. Mm-hmm. So it was the speed at which the law changed and the practices changed without discourse, and that this consensus was announced with most therapists knowing little to nothing about the issue. And I felt it was very clearly communicated that all of a sudden these weren't issues that were safe to ask questions about. And it was head spinning, and it was hard just to even get your mind around. I remember somebody saying at one meeting I was in, like, well, what's the rationale for not letting somebody, transition? Why, what's the rationale for that? And nobody had a response, because it's like, we hadn't thought about it at all. Compare this to like other debates in the field, like psychoanalysis versus CBT, or like social versus personality, or genes versus environment. There are these controversies in psychology that are these decades and decades long debates with like lots of researchers on both sides, thousands and thousands of studies and papers, and they're still unresolved. And then you see this issue where it's just rolled out in a blink of an eye, that now there's a consensus and you can't ask questions. And there was never a period of robust debate.
I've said this many times. I think a lot of this is due to being so haunted by the gay rights movement and so
Yeah.
much malpractice and really, frankly, cruel treatment on the parts of therapists and clinicians and counselors, gay people, back in the day and not too long ago, that there's just an absolute terror of repeating that. But like, it's a totally different phenomenon, especially now with, this new population. So there's really nothing that happened. There wasn't one article or some 60 minutes special that changed everything. Like, what was the source? Was it Tumblr? I mean, this is like, I just
Well,
constantly rack my mind over this.
I think it's activists. I mean, they got a ton of money. Some of the LGBT organizations just got a ton of money, and they got an enormous amount of influence very quickly. And and their counterparts, which had been I think mostly conservative Christian groups, kind of all agreed around the same time that they weren't going to fight on these issues. Most of them agreed they weren't going to fight on these issues at the same time. So there was just all of a sudden there was tons of money and influence on one side and nothing on the other side. Yeah. But even basic questions, I'll tell you something that I mean, I bet it's come up on your podcast, but how you can't change your genitals and get all the surgery to become, to appear like the other sex without state-of-the-art technology. And that didn't exist that long ago. And how can you be born in a way that requires state-of-the-art technology in order to exist? And it's interesting how the movement, they kind of avoid language about trans identity being genetic, because as soon as you think about genes, you think about chromosomes. And so there's this other argument that it's almost like it's this theological thing where you have a soul and your soul has a gender,
right?
And God made a mistake in terms of putting the soul in the wrong body, and there's this kind of it does have this a lot of theological aspects to it that don't really fit with scientific worldviews. But it's just but there are, as you know, but there are just dozens of questions about what this means, about what this is, and why it works the way that it does. I mean, yeah, but it's just I never, these debates, at least in the mental health field, I think essentially never happened.
Yeah. But there are so many clinicians who are just primarily activists. And I'm wondering, are there certain institutions or are there certain training? Is there do they get trained this way? I mean, we talk about this often here in terms of teachers and ed schools, the people who are now tending to become teachers, public school teachers. It tends to be a certain kind of person now. I mean, you could just take a snapshot of a classroom of people in an ed school, and they're not ladies wearing pearls. They are. There's a lot of rainbow hair, not exclusively or anything, but a lot of it. Is that the kind of population that's going into therapy as well, becoming therapists?
I don't think I knew anybody who had rainbow hair. But it's hard to distinguish what most people believe versus what most people are pretending to agree with. And I don't know the answer to that. It's it's an interesting thing how you're talking about ed schools, it's you control the diversity apparatus at the ed school, and then you have a say over hiring, and then you push the faculty of the ed school to be all your ideology, and then you get the students to be all your ideology, and then you get the teachers. There's a way that they've hacked into these hierarchical structures to coerce people from top down into, and you do see that in terms of the professional organizations and clinical psychology tend to be a lot more activisty, a lot more one-sided, and they do the accreditation of the academic programs, like the PhD programs need to be accredited by the APA, and they do a lot of the continuing ed trainings. And so there's a way that it gets kind of top down imposed on people.
Yeah. I want to ask you too, we're talking about patient populations, people who really are, whose needs are not being addressed or even studied. It's obviously people outside of cities. I mean, I'm thinking of people in rural populations. You've got working class, lower class, white people, all kinds of people. I don't even think this is racial, actually. So let me take that back. I mean, you've got people in rural areas who have a lot of problems. They've got relationship problems like everybody else, and professional problems, and substance problems, and problems with their kids, and everything. Like, how are they supposed to find a therapist? I'm assuming that they're going to go into like a local mental health center, or there's maybe like a few therapists in town. I think often they call them counselors. I always thought that was very interesting. I moved to the Midwest in the early 2000s from New York City, and everyone was in therapy in New York, and suddenly you'd go to counseling instead of going to therapy. It was just what it was called. What is it like for people in a more rural community in terms of their relationship with the clinical setting at all?
Yeah, I think it's much harder to find providers. I mean, there's telehealth now, so that's more normal that you can get a therapist on Zoom, even if you live in a remote location. There are licensing issues. Psychologists have something, there's an organization called PsyPact, where if you're licensed in one PsyPact state, you can practice in any of them. And that's like about 30 or 40 states. It's like a ton of states. And psychologists increasingly can practice in most states, but I think access is absolutely limited, and the quality of the training of the providers in rural areas tends to be much lower. So there are good therapists that do work in a lot of areas, but they tend to have less extensive training.
And what do you think about outfits like BetterHelp, for instance? BetterHelp, not a sponsor of this podcast at the moment. They sponsor all the podcasts, but so we're allowed to talk about them. What do you make of that?
I should know this, but what they do is basically they'll pair you with a Zoom therapist. Yeah. Is that their service?
Yeah, yeah.
My guess
so
is
an app. I mean, I think it's actually not even Zoom. Like, you can chat with them, you can text with them. It's an app.
Okay, see that I don't like. That I don't like, because I think that, like, even Zoom I don't love. I think there's a lot happening in an in-person interaction that, like, a lot of therapy is nonverbal. Like, when there's a difference between talking into the ether and having your feelings connect to somebody else. And sometimes talking with somebody and having them get it, you actually feel like you're processing, and you get some nurturance from the interaction with another person that's really meaningful. And I think even that is harder on Zoom, or sometimes on voice calls. On text, I don't see it happening at all.
You have to use a lot of emojis.
And then it's misattuned and it's weird. And the idea that you can do it on demand doesn't seem good. I mean, so that doesn't seem like, and I would bet that, just the economics of it makes you think that they would get the least skilled people, because if you could do something else as a therapist, you probably would. So I don't know. I can't think off the top of my head why a really talented therapist would work for BetterHelp.
Well, I always feel like they're very young, or they're like in training. I don't know if you.
They're probably like a master's level clinician who doesn't have another option.
Huh.
That's all I can think of. I mean, maybe that's brutal, so it might be missing something important. But that's who I'd guess it would be, on a platform that's probably not the most conducive to therapy to begin with.
Is it hard to get a job, though, if you are in mental health profession? Because all we hear about is there's just lack of mental health care. And I mean, like, how hard is it to get a job?
I mean, it depends on, it's not hard for a licensed clinical psychologist. It's not hard for a psychiatrist. Somebody who got a master's in family therapy and doesn't have any clinical experience, or I think it depends on the person, or on the context. But yeah, I think and they need hours before they can get licensed, and I don't. I think there are people who have certain degrees where it's hard to where BetterHelp is their best option.
Mm-hmm. Do you think that most therapists go into this profession because they want to help people? Why do people go into it?
You'd hope so. Yeah, I think so. It's immensely, as somebody, if I feel like a patient of mine makes significant growth and progress and feels better and is improving, and that's an incredibly gratifying thing. That really is a huge perk of the field. So I think that's really it. I think for most people, there's probably a variety of like individual factors. Maybe like one of them, I think Nancy McWilliams, who's a very famous psychoanalyst, wrote about like therapists having intimacy issues, like craving certain types of intimacy, and there's definitely something. You definitely have to enjoy being around a lot of emotion. I think that's a good, like, if you have that trait of like there are people who really like emotion and people who really don't. If you don't, it's not a great job for you. I think there's also issues about wanting to hear what people are thinking and know people in a particular way. So I think there are people who maybe want closeness, want emotion, there can be, this isn't the most flattering towards therapists, but there can be a kind of voyeuristic gratification that therapists get, that they like, which I think is a universal thing on some level, that people like hearing stories and interesting stories. But, so I think there's all different types of like personality factors that might lead someone to want to become a therapist. I hope helping people is one of them. But
do you think that therapists are more likely to have mental health issues themselves?
I think that if you haven't ever had any mental health issues and you've never been in therapy, I don't think you would be a very good therapist. I think having the experience of having suffered and been through therapy and seen what works firsthand is invaluable as a therapist. So I kind of am skeptical of, like, there are some therapists who have never been in therapy themselves, and that is like unbelievable to me.
You have to go to therapy to be a therapist, though, right? Yourself, don't you? You don't?
No.
I mean, well, to be an analyst, really? To be an analyst, you have to be an analysis, right? Right?
That's right. To be a psychoanalyst. Okay. But that's a totally different degree and process than being a therapist. And therapists do not have to go to therapy ever.
Wow.
So it's which is crazy. There are reasons why, they decided that it was problematic for programs to force trainees to go to therapy. But that doesn't make any sense to me. The best therapists would be people who have like actually been through some serious shit. This is my take. Been through some serious shit, seen therapy working and not working, and found something that really worked for themselves, and then use that to help their patients. I think that's like a great background to have as a therapist. I think there are therapists who go into the field hoping that they're going to find the thing that helps them, and maybe they don't, or maybe they overgeneralize or things like that. But yeah.
Interesting. Are more people going to therapy now, or are less? I can't quite tell.
I think it's more. There's definitely data somewhere on it.
Okay.
I would guess more.
Yeah. I've noticed this life coach phenomenon that like a lot of people are sort of hiring coaches and taking this very kind of practical approach to sort of macro problem solving in their lives. And it's seems like it's this strange alternative to therapy. Not strange, but it's just something I've noticed over the last couple of years.
It's just the life coaching world is just the Wild West. I mean, there's no regulation of what that term means. So
well, I think you have to be in your 20s to be a life coach. As far as I can tell. The less life experience you have, the better coach you are, evidently.
But it's there's no requirements around training or education for the titles. So I think it's zero. But it's like it's just the Wild West, and I'm sure there's just a huge gamut of what people are doing under that title.
Yeah. It's that'll be a different conversation. All right. Well, Andrew, thank you for speaking with me. The Open Therapy Institute. Congratulations on starting that. It sounds extremely timely.
Thank you so much for having me. It's great to be here.
Yeah. Hopefully we'll talk again sometime. Thank you so much.
Absolutely. Okay. Bye.
That was my conversation with Dr. Andrew Hartz. He is a practicing clinical psychologist in New York and the founder of the Open Therapy Institute. Once again, if you are not yet a paying subscriber to this podcast's Substack page, meghandom.substack.com, you should become one now for many reasons, among them that for founding members, I will be hosting a Zoom hangout in a few weeks, Sunday, October 29th at 8 p.m. Eastern Time. You can ask me all kinds of things. We get together, we talk about the various episodes, gossip about the guests. It's a lot of fun. Also, a little unspeakeasy news. I will probably in the next week or so announce the first 3 retreats of 2024. We're going to do 6 in total all over the country, and I'm going to tell you about the first 3 that will happen in the early and mid-spring of next year. So listen up for that, or go to theunspeakeasy.com and get on the mailing list. You can get some problematic merch while you're at it. Hats, t-shirts, all kinds of things. Let your problematic flag fly. I'll be back next week with another super nuanced guest. Thanks for listening. See you next time.